Peripheral occlusive disease. It is a, see, usually the students don't want peripheral arterial occlusive disease when the case is being allotted. Am I right? But in Karakonam, it is other way around. Everyone wants peripheral arterial occlusive disease because it is easy to come to the diagnosis if you know certain principle in peripheral arterial occlusive disease. Is this chap who is standing here is Dr. Van Nowels, who is the mentor for me in general surgery. I have done many camps, surgical free camps in my place, Trivandrum, and I got opportunity to operate on so much thyroid patients along with them. He is the Dr. Van Nowels. My guru, Dr. Sunil Agarwal, he is a general surgeon. Then he became vascular surgeon. He was HOD of general surgery as well as vascular surgery in CMC Vellore. He is my mentor in life as well as in my surgical career. I always remember him. He is no more now. He met with an accident and died. So coming to the topic, what is a peripheral artery? Anyone? What is a peripheral artery? Artery other than those vessels supplying heart and brain. The heart and brain arteries called central arteries. All the other, even aorta is peripheral artery. Aorta is also a peripheral artery. Yeah. Causes for arterial occlusion. So we are going to discuss the peripheral arterial occlusive disease. Causes for occlusion, commonest causes 90% is atherosclerosis. Then comes thromboangiitis obliterans. Then vasculitis are the rare causes for arterial occlusion. This picture you remember very well because with this only you are going to come to a diagnosis. This is aorta, abdominal aorta divides into common iliac, then it is the internal iliac, then comes to external iliac, then common femoral that separates into profunda and superficial femoral, then it comes to popliteal fossa and anterior tibial, posterior tibial and peroneal artery. See, remember, this is the picture you should remember before asking the complaint. So aorta iliac, common femoral, then comes, common iliac, common femoral, then come popliteal, then trifurcation. Okay. So each level the occlusion produce different symptoms. The symptoms of lower limb ischemia is only 4. Claudication, rest pain, ulcer, chronic non-healing ulcer and gangrene. Claudication, rest pain, ulcer and gangrene. Here the claudication is always best managed by medical therapy. We don't do any vascular intervention for claudication. This is for your level. Claudication is managed only medically. Whereas the rest pain, ulcer, gangrene, it needs some surgical intervention. Either endovascular or open procedure. Either endovascular or open procedure. What is claudication? So claudication means a crampy muscle pain. It due to muscle ischemia, due to accumulation of substance P. Okay. Usually in the calf region. Spelling thappa edhirukanga yaro. Yeah. Nama PG da. Usually in the calf region. Pain only when the muscles are working. Pain occurs when the muscles are working. Never at rest. Never at rest. It is relieved by taking rest. Okay. These are all the cardinal features of claudication. Okay. When there is aortoiliac disease, imagine here if it is occluded at the level of umbilicus, just below the umbilicus aorta divides. When it is occluded, they have bilateral gluteal claudication and bilateral lower limb claudication. Any patient come with bilateral lower limb and bilateral gluteal, the occlusion is at the level of aortoiliac. They have also impotence because iliac artery also occluded. So the internal iliac which causes this supply to the genitalia, that will affect and produce impotence. And iliac artery occlusion, either common iliac on left side or right side, they have unilateral gluteal claudication and unilateral lower limb claudication. Imagine if it is occluded just below iliac, they have gluteal plus lower limb claudication. The next level, external iliac or common femoral, they have lower limb claudication. The next level, femoropopliteal junction, that is in the adductor canal. In the adductor canal, if it is occluded, they have calf claudication and foot claudication, or below calf, below the level. And lower tibial and plantar artery occlusion causes foot claudication. So imagine if the foot is having pain, the occlusion is the plantar level or lower tibial. If the calf is having pain, claudication, the level is little above femoropopliteal junction. If it is in the thigh or the whole lower limb, that is common femoral and iliac. If it is little above iliac artery, they have gluteal as well as lower limb. Depending upon the area of occlusion, patient will have claudication. With this, we will be able to come to a clinical diagnosis of which level is occluded. Then after palpating the pulse, the diagnosis will be confirmed. The rest pain, it is a continuous pain, usually in the tip of the toes. It worsens at the night, aggravated by elevation and decreased by hanging the leg. Usually patient sits in the ward and compresses the lower third of the leg. So when you give compression to the lower third of the leg like this, it stops the impulses, the pain impulses which going to the brain. So by giving the compression to the lower third of the leg, it prevents the pain impulses going forward to the brain. Gangrene. See whether there is a gangrene, whether it is a dry gangrene or wet gangrene or mixed gangrene. A pure peripheral arterial occlusive disease produce dry gangrene. A pure diabetic will produce wet gangrene. A POVD with diabetes produce mixed gangrene. Okay. So usually in this place, diabetes is very common. You may be getting that mixed gangrene. It is pure POVD. Dry gangrene is pure peripheral arterial occlusive disease. Other symptom, these are all not very common. Paresthesia because of the shunting of the blood from the skin to the muscle, and superficial thrombophlebitis. In history, you ask for claudication, rest pain, gangrene and ulcer. Then come to other system. See, all the arterial disease are generalized, never localized. All the arterial disease are generalized, never localized. You have to ask for symptoms of other system. Cardiac symptom, exertional dyspnea, exertional chest pain, orthopnea, paroxysmal nocturnal dyspnea. These are the things you should elicit in the history. Then comes CNS, fainting and transient blackout, amaurosis fugax, and sensory loss in the arm, leg, face. TIA means transient ischemic attack. RIND means reversible ischemic neurological deficit and stroke in evolution, in this order. So ask for this history. If it is present, it is CNS ischemia. Maybe the carotid artery is the culprit. If it is occluded, you may get these symptoms. An abdominal system symptoms, postprandial pain, that is called abdominal angina, especially after 30 to 60 minutes after taking food, and diarrhea, weight loss. See, all these three systems you ask in the history: CVS, CNS, abdomen and lower limb. Then come to the physical examination. In physical examination, this pallor is more in acute limb ischemia, not on chronic limb ischemia. When there is a congestion like blue, it is usually due to severe ischemia in the lower limb. And then look for gangrene. When there is a gangrene, you look for line of demarcation, the surrounding skin, whether it is edematous, whether it is color, whether it is tender or not. All these things you look into the gangrene. On palpation, warmth is very important. In chronic lower limb ischemia, the limb will be usually cold. But when there is associated infection because of the ulcer, it may be warmth also sometime. Then we don't usually check capillary refilling, venous refilling. Capillary refilling is the very important one. That is also decreased in chronic limb ischemia. And muscular atrophy and palpation of the peripheral vessel. These are all the 4 things you look into the palpation. This is the way you check capillary. What is the normal capillary refilling time? Less than 5 seconds. Right. If it is more than 10, it is ischemia. That palpation of vessel, you know, it is a dorsalis pedis lateral to the extensor hallucis longus, posterior tibial in between the tendo achilis and medial malleolus. And then popliteal artery, femoral artery, right? Radial artery, brachial artery, subclavian artery above the middle of the clavicle, subclavian artery, and carotid artery, superficial temporal artery. All these arteries need to be palpated in your examination. I repeat, dorsalis pedis, posterior tibial, popliteal, femoral in the lower limb, and also radial, brachial, subclavian, carotid, superficial temporal artery. I forgot to mention the ulnar artery also. So all the vessels to be palpated, right? Then auscultation, bruit. When there is a stenosis, femoral artery, when the blood flow, turbulent flow through the stenotic area, you will get the bruit. Femoral artery bruit, carotid artery bruit, renal artery bruit. You should be able to hear when there is a stenosis. The final diagnosis, how will you tell? A chronic lower limb ischemia, usually the case will be given to you. We don't usually receive acute limb ischemia. We usually receive chronic lower limb ischemia, the level of occlusion and cause of occlusion. With that, it finishes the diagnosis. Imagine if it is aortoiliac disease, patient will have bilateral lower limb claudication. Am I right? And bilateral lower limb claudication. No pulse will be present on both lower limb. All the pulses will be absent in aortoiliac disease. Same thing happens if it is a unilateral common iliac occlusion. They have gluteal and lower limb claudication. One side pulse will be absent, opposite will be completely normal. If it is an external iliac or common femoral artery occlusion, femoral artery pulse will be absent, popliteal and dorsalis pedis posterior tibial will be absent. You understand? If it is a common femoral artery occlusion, nothing will be there below. If it is a femoropopliteal junction occlusion, they have cough claudication, but femoral is palpable, popliteal and posterior tibial dorsalis pedis is not palpable. Okay. Then lower plantar arteries, if it is occluded, lower tibial artery, if it is occluded, either anterior tibial or posterior tibial will be absent or both may be absent. Right? This is the way you locate the lesion. The Rutherford grading of chronic lower limb ischemia: grade 1 mild claudication, grade 2 moderate claudication, grade 3 disabling claudication, not able to do the regular work, and grade 4 rest pain, grade 5 minor tissue loss, grade 6 is major tissue loss. Minor tissue loss means ulceration and gangrene of the digits, confined to digit, toes, whereas major tissue loss beyond the metatarsal. The last one terminology everyone should know: chronic limb ischemia, critical limb ischemia. The recent Bailey says critical life-threatening ischemia, CLTI. That's what the new Bailey says. Critical limb-threatening ischemia, CLTI. Previously we call CLI. Now they add T also. ABPA less than 0.4, toe pressure less than 30, and rest pain, ulcer, gangrene. If 5, ABP less than 0.4, toe pressure less than 30, when there is a rest pain or ulcer, non-healing ulcer and gangrene. This is called critical limb ischemia. All these critical limb ischemia patients need imaging. You should do duplex, you should do CT angiogram, and vascular surgery intervention is needed. Okay, the critical limb ischemia patient needs some intervention, either angioplasty or bypass or endarterectomy. Okay, there are 4 procedures to improve the blood flow. Number 1, angioplasty. Number 2, angioplasty with sending. These are the endovascular procedure. Open procedure is bypass and endarterectomy. I will show one picture for endarterectomy. I will show you. What I thought when I study MBBS, endarterectomy means cutting the vessel and rejoining. That's what my understanding when I was medical student. But actually endarterectomy is Yeah, this is endarterectomy. You put the clamp proximally and distally and remove only the plaque. The plaque will occlude the lumen. You remove the plaque and suture with a vein patch or PTFE patch. Okay. So bypass is by when there is occlusion here from proximal to distal, you are bypassing. You don't need, we don't ask so much, we don't expect so much from you. This is the bypass. When there is occlusion here, you do proximally connection and distally connection. We always connect the normal artery to normal artery. Okay, normal vessel, pliable vessel to another pliable vessel. Put a graft proximally so the blood will bypass the aortoiliac disease. This is iliofemoral bypass. Then one more bypass is when the patient is very sick, cardiac reserve is very poor, the patient is having lower limb ischemia, you can divert the blood from the axilla to femoral artery, axillofemoral. When the patient is having severe cardiac problem, where his ejection fraction is very poor, not able to tolerate the major surgery, you can revascularize the lower limb by taking the graft from axilla. This is called non-anatomical bypass. So anatomical bypass, non-anatomical bypass. Okay, in nutshell, all arterial problem are generalized, never localized. So examine the lower limb, examine the cardiac system and evaluate the neurological system and abdomen also for bowel ischemia. So you have to investigate according to that. Then when there is a critical limb ischemia, patient needs some intervention, vascular surgery intervention, either bypass or endovascular procedure. The endovascular procedure are angioplasty with stenting. Open procedure are endarterectomy and bypass. The bypass may be anatomical and non-anatomical. This is a broad idea. According to your patient, you can tell the management. Who is the presenter? The next session, peripheral arterial.
So now we have case presentation by Meghna Krishna.
Cases are generalized, not localized. Claudication is always managed conservatively, best medical therapy. Critical ischemia need imaging and vascular surgery intervention. Amputation the last resort in peripheral arterial occlusive disease. Life-threatening sepsis is the only indication for amputation. This Rangabhashyam is the gastroenterologist in Tamil Nadu. He is the one who started MCH gastro in Tamil Nadu. He is FRCS from London. I took his take-home message for everyone when he finished the conference. Always be proud of your profession and control your anger and tongue and have a positive attitude in your life always, whatever happens. And do exercise every day, 45 minutes per day, 5 days a week. And do pray also every day. And at least have one meal with your family to improve the emotional bonding between you and your family. This is a lifetime take-home message, not for this session.
Susruda identified the first picture as per the history. And Susruda is given his pictures. Any idea? The natural suture? Yes, ant. Yes. Yes. What they do is they approximate the wound, take the ant on one hand and ask the ant to, or make the ant to bite it. Okay, just like this. And after that, they just remove the body of that ant. The head is there. So the head will remain there for 10-15 days. By that time, the ant will be totally dissolved and the wound will have an excellent scar. Still, we are using the same technique, stapler. Almost same as, only thing is, we are moving the total body. The stapling device is to be removed. Okay. So, you are from? Your good name?
Krishna. Meghana Krishna.
From where?
Kollam, sir. Yes.
Okay.
Kerala.
Mera ur da na. So it's so the first threatening, no questions. Am I right? Studying where?
To my best, sir.
Eh?
To my best.
Studying where?
Shabrigiri.
Eh?
Shabrigiri Residential School, Anji.
Medicine? Here.
Yes, sir.
Okay. Anybody from outside this Kanyakumari Medical College? All of Kanyakumari only? Outside Medical College also there. Is there? How many of you? Raise your hand. Which medical college? Tirunelveli. Ama. Who brought? One. They will travel across the world, globe. Then why do you want to? Your girlfriend brought you here. Am I right? That's the best companion. Okay. See, this is a session for you. You can ask questions. So you prepare one good question, and the best question will be given an award by Dr. Jailal sir. Okay. Not me or by Punithan. Dr. Jailal will give you a prize. Okay. Get ready for the best question in this. Okay. Yes, Meghana, please.
Good afternoon to one and all present here. So, Mr. Simon, a 78-year-old male who is a tailor by occupation from Periyakadu, belonging to the lower middle class, came with chief complaints of pain in the left lower limb for the past 2 months. History of the presenting illness. Patient is a non-case of type 2 diabetes mellitus for the past 3 weeks. He developed pain in the left calf muscle while walking 2 months ago, but he could still walk with effort. The pain was a cramping type, insidious in onset, progressive in nature, radiating from the calf to the foot. He used to get pain after walking a distance of 500 meter initially. The pain disappeared after taking rest for a few minutes and reappeared on walking similar distance again. Right now, he has pain on walking a few feet and he is unable to walk past 100 meters. He has no history of rest pain. He has no history of change in pain with no history of pain in no history of change in pain with posture. He has history of pricking pins-like sensation over the dorsum of the left foot. He has no history of swelling or redness in the lower limbs. He has no history of impotence, no history of any ulcers, no history of any blackish discoloration of the skin, no history of similar complaints in the other limb. He has no history of fainting, transient blackouts, blurred vision. He has no history of chest pain, and he has no history of abdominal pain. Past medical history. The patient is a newly diagnosed case of type 2 diabetes mellitus on medication for the past 3 weeks. He has no history of hypertension, cardiac illness, stroke, transient ischemic attacks. He has no history of hyperlipidemia, and he has had no previous surgeries or blood transfusion. Drug history, he is taking medication for diabetes mellitus, metformin and glimepiride for the past 3 weeks. He has no history of any allergies. Personal history, he consumes a mixed diet of vegetarian and non-vegetarian food, and he is a habitual smoker for the past 48 years using 8 BDs per day. His pack index is 32. He occasionally consumes alcohol and he has normal bowel and bladder habits. He has no sleep disturbances. Family history, the patient stays with his daughter. He has 3 siblings and 3 children. None of them suffer from any ailments. Summary, a 78-year-old diabetic male with complaints of intermittent claudication in the left lower limb with claudication distance of 100 meter and paresthesia, who is a chronic smoker, is most probably a case of peripheral vascular disease of atherosclerotic etiology and occlusion at the level of the popliteal artery.
Very good. So, it's a good history. Start from the end. Why do you say it's occlusion at the level of popliteal artery?
Because the pain is at the level of the calf muscles, hence the level of occlusion is at the level of popliteal.
Very good. Okay, fine. You said there is a patient history of stroke and TIA. What is TIA?
Transient ischemic attacks. So it is a focal neurological deficit that resolves within 24 hours without any evidence in imaging.
Which lasts more than 24 hours?
It is
Yes, you're right.
reversible ischemic neurons.
RINT, reversible ischemic neuronal damage. Okay. And what is RINT? How long it is? Yes, you're right. 7 days. Yes, it's 48 to 72 hours. It can up to 7 days also, sir. If it persists beyond that, it's called a stroke. Okay? So that's it. Yes.
What is the definition for claudication pain?
Claudication pain is a cramping type of pain that is produced on exercise, most probably in the calf muscle, calf area, that is relieved by rest and it is reproducible.
Very good, excellent. What is rest pain?
Rest pain is a pain that is present most probably in the extremities of the limb, that is in the toes, present even at rest, and it is a burning type of pain. It is increasing on elevation of the legs and relieved by
There is
hanging.
a definition for rest pain. Did you read about the definition for rest pain?
Yes.
Rest pain occur during rest.
Yes.
Why there is pain during rest? Patient is simply relaxing, lying down. Why there is pain during rest?
Due to nerve damage,
How?
arterial occlusions of blood.
Seriously, what happens?
Meet the demands during rest.
Then why is not happening? Patient is walking. Patient is standing only during rest.
It is.
Why? Patient doesn't have any pain. He is standing but only lying down in a sleeping sickness. Yes? Telugu.
Arterial flow is
So when there's severe occlusion through the collaterals, blood is flowing only through gravity. When the patient stands, the gravity gets cancelled. Okay, with the heart and the limb at the level, same level, there's no gravity. So no gravity means there is no trickling of blood. No trickling of blood reaches the distal part. So whatever be the blood reaches there is insufficient for the nerves to survive. Nerves have one structure which cannot regenerate or very poor regeneration capacity. Okay, all of the skin, muscle, everything has some regeneration. So the muscle dies, it's almost a permanent death. So it's crying. Okay. So because lack of gravity happens in the rest pain. Okay.
Listen to this definition. Rest pain is pain at rest for more than 2 weeks with adequate analgesia,
with adequate analysis.
including an opioid analgesic with ABI less than 0.4 and toe pressure less than,
30 millimeter,
ankle pressure less than.
50 millimeter.
Good.
He's taking occasional alcohol.
Yes,
Is it good or bad?
bad.
Why? Why alcohol? Drinking is always bad. The thing is, alcohol causes some amount of neuropathy. Okay? So in these patients, the symptoms will be delayed or percent will be delayed if the patient is taking alcohol. Okay? Because of the diabetic neuropathy which is aggravated by the alcohol itself. So the person at a more advanced stage comparing to these people. Okay? If there is alcohol component is not there, the neuropathy will be less. So alcohol is not good for diabetics, vascular disease also. Okay.
And what is neurogenic claudication, arterial claudication, and venous claudication?
Neurogenic claudication is caused due to conditions like lumbar stenosis.
I am not asking for the causes.
What is the character?
How do they present?
But how do they present?
They
You
are,
have written it in the history.
they are all classically called, yes.
Yes. So if neurogenic claudication is relieved by bending forward position, venous claudication usually develops bending.
No. Kuduma.
Come here.
It changes according to the position of the patient. Okay, sometimes they take them weight, they have pain. Leaning forward, they have pain. So raising the limb, they have pain. So changes with the positions.
You
Then
can remember it easily. For neurogenic claudication, you will get pain in the first step. For arterial claudication, you will get pain after walking for some distance. And venous claudication, if you walk, it will reduce. Okay.
One more claudication is there. Joint claudication. Arthritic claudication is there also when there is inflammation of the knee joint. Here the patient's pain changes according to position of the knee joint. When it's flexed, pain is more extended, pain is less, something like that. Okay. Okay, fine. Anything else?
Patient is an elderly male of moderate built and nourishment. He is conscious, cooperative, and well-oriented. He has no pallor, no icterus, no cyanosis, no clubbing or no lymphadenopathy, no pedal edema. He has arcus annulus in his eyes. Vitals, pulse 68 per minute in the left radial artery with normal rhythm, volume, and character. No vessel wall thickening. 72 per minute in the right radial artery. No radioradial delay and no radiofemoral delay. Blood pressure 130 bar 80 millimeter mercury in the left brachial artery and 126 bar 80 millimeter mercury in right brachial artery. Respiratory rate is 18 per minute and temperature is afebrile by palpation. Local examination of the left lower limb, inspection on supine position. He has a normal attitude. Limping gait was present. He has no deformity and no limb shortening. No discoloration of the skin was present. Signs of ischemia were present such as thinning of skin, loss of hair, and brittle nail and transverse ridges. Then capillary filling time was 20 seconds and venous filling time was 15 seconds. No wasting or edema of the limb, no ulcers, no gangrene. In the right lower limb, it appears to be normal and a scar of size 4 cross 3 centimeter was present in the anterior aspect of leg. Palpation, there is local fall in temperature of over the dorsum of left foot as compared to the right foot that extended up to the ankle. Same temperature was present over the legs and thighs on both sides with no local rise in temperature. Delayed capillary refilling time and venous refilling time. The patient was able to perceive sensation in the limb. The angle, hip and knee flexion and extension movements were present against resistance. No inguinal lymphadenopathy. Then palpation of the peripheral pulses. Normal pulses were felt in over the right femoral, popliteal, posterior tibial, anterior tibial and dorsalis pedis arteries. In the left leg, normal pulses were felt in the femoral artery and a pulse was absent in the popliteal artery, posterior tibial artery, anterior tibial artery and dorsalis pedis. In the upper limb and all the peripheral pulses were felt equally on both sides.
That is the occlusion there.
Femoropopliteal segment. Adductor. On auscultation, no bruit were heard.
Okay, you said some nail changes. Any changes? What are the nail changes in ischemia?
Brittle nail and
Yes.
transverse ridges. Transverse ridges.
Ridges. What is transverse ridges? Anybody why there is ridges in a ischemic nail? Because when the nail forms, some face there's good vascularity, some face bad vascularity because the vessel is there. So depending on that formation and type of vascularity, the color changes. So you get different types of colors depending on that. Okay. Yes.
Tell any 4 signs of atherosclerosis.
Arcus annulus, obesity,
Sorry? Obesity.
Obesity.
sandalasma,
Then
San Thomas.
sandalas.
one more.
Then vessel wall thickening.
You can fill it. You have cord-like thickening of arteries. Where do you palpate popliteal artery?
Popliteal artery is felt in the lower popliteal fossa against the tibial
Tibial?
tube.
Simply patient standing?
In at 40-degree angle in the supine position.
Yes. Against what bone?
Tibial
Tibial condyle.
Medial tibial condyle.
So you got a very good popliteal pulse. You are quite happy about it. It's very bounding popliteal pulse. Is it normal?
No,
Why?
Because it is lying deep in the popliteal fossa, so it may be due to any aneurysms.
Yes, very good. Okay. Yes, you're passed. Yes. So, so never think that not getting a pulse is abnormal. Most of the people, pulse is not palpable. If you get an excellent pulse, again, that is pathological. It indicates aneurysm. How do you palpate dorsalis pedis?
Lateral to the extensor hallucis longus tendon in the first metatarsal space.
Which carpal bone? Which tarsal bone?
Navicular.
Okay. Posttibial?
Posterior tibial between the medial malleolus and the Achilles tendon over the calcaneum.
Femoral?
Femoral below the midinguinal point, head of the femoral.
Which condition the head is absent? Which condition the head is absent and pulse is not palpable?
Aortoid.
No. Patient is brought to casualty, you examine the femoral pulse, it is not there. But you get the distal pulse is present.
Collat.
Yes, please. Dislocation, very good. Which dislocation? Post dislocation. What is the name of the sign? Yes, vascular sign of Marath. Okay, very good. Who is that? Yes, excellent. Congratulations. So, how do you palpate carotid pulse?
Carotid pulse is felt in the lateral, medial to the sternocleidomastoid muscle.
Over which bone?
C6 vertebrae.
What precaution will you take when you are palpating carotid pulse?
Only one.
Only one side. Never palpate both sides of carotids. Okay, fine.
Systemic examination in the cardiovascular system, S1, S2 heard, no added sounds were found. Respiratory system, normal vesicular breath sounds were heard, no added sounds. CNS, no focal neurological deficit. Per abdomen examination, abdomen is flat, umbilicus is centrally placed, no dilated veins. No, on palpation, abdomen is soft, no tenderness, no guarding, no rigidity. On percussion, no free fluid is present and normal bowel sounds are heard on auscultation.
So, your diagnosis?
Diagnosis, peripheral arterial occlusive disease affecting the left lower limb, probably due to atherosclerosis causing thrombosis, occluding at the femoropopliteal.
Any other cause? You said probably due to, so probably due to any other cause?
TAO.
TAO, what is TAO?
Thromboangiitis obliterans.
Yes. So is it a 3A or other in this patient? What is common? What is more possible?
Atherosclerosis.
Why? What are the points against TAO?
So it TAO usually occurs in small and medium-sized vessels first, and its onset is usually before the age of 45 years old, and it is probably it is found in males, and smoking should be present, and they should not have any risk factors for atherosclerosis such as diabetes, which is present in this patient.
Okay. What is the pathology of TAO?
Pathology is due to hyperplasia of the intima.
Single word. So pan arteritis. And which other structures are involved other than artery?
Veins and nerves are.
Veins and nerves are also involved. If you, in a case of TAO, if you examine the upper limb, what is significant?
Upper limb.
Say a 38-year-old heavy smoker coming with absent dorsalis pedis posterior pulse absent. Then you examine the upper limb. Which pulse is important? Ulnar is usually involved. Ulnar may be absent. So your diagnosis is atherosclerosis. Okay. What do you do for this patient?
We have to do investigations.
What is not time? So what are the major investigations?
Duplex.
130. Okay.
Doppler and duplex.
Eh?
Dopplers.
Okay. Doing a Doppler in the artery, what all things we look for?
the site of the vessel wall condition will be checked. So the flow,
Flow.
then pressure using ABPI,
Okay. Very good. Excellent.
then if the collateral,
Ultrasound, Doppler. That's too much. Okay, in the flow, what all things, sir? You put the probe on the artery and you see the flow. You put the color. So, what all things?
direction of,
Yes, one is direction of flow. Then,
then
anybody? Yes? By putting the Doppler probe on the artery, what all things you look for? Of course, one thing is there should not be flow. Okay, there should be color flow, which happens. Don't think the flow is, artery is red and vein is blue. It is, don't think like that. Red shows direction to one direction, flow to one direction, and blue shows flow to the opposite direction. Okay, so don't think that always artery is red, vein is blue. Doppler. Okay, there should be flow. Second thing is any obstruction, and third thing is flow speed. Okay, you should assess the speed of at different sites. Okay, and when there is a stenosis, the speed will increase or decrease? Increase. So you have to look at the flow velocity, and at any site, if the flow velocity is increasing, that means there is an obstruction or stenosis. Not obstruction, but a stenosis above that point. Okay, so that's about the flow. Then second thing is wave pattern. What are the waves? What's the typical wave pattern of an arterial flow?
triphasic.
Triphasic, very good. What are the tri? A is a first positive flow due to, yes? Chalgo. Systolic. Heart is contracted, the systole is being transferred, that's called a positive wave. Second is early diastolic, that's a negative flow, and there is a small positive flow, that's called V, that is due to? No, not late diastolic. It's not late diastolic, it is. How can diastole produce a positive wave? Yes,
Recoil.
when the pressure comes, artery dilates. Okay? Once the artery dilates, it has to come back to normal position. It will produce a small pressure back. That recoiling of the artery happens, and that is producing the small positive wave at the end. Okay? So these three waves produce the triphasic wave, and when there is obstruction starts, which wave will disappear first? Yes? Recoil will disappear fast, the small and first will appear fast. Then that wave is called a biphasic one. Again the stenosis goes up, the negative wave disappears, becomes a monophasic one. When there is obstruction, all the three waves disappear, it's called a aphasic wave. Okay. Yes, then?
Then CT angio,
Straight away, you do CT angio for all patients?
duplex.
You said
Indication for CT
CT
angio.
angio
We
is
don't do CT angiogram for all the patients. We do duplex for all the patients to know the level of block,
length of block,
length
lesion,
of block,
etc.
everything you can see.
You missed one, you said one thing, ABPI. What is ABPI?
Angle brachial pressure index.
Okay, how do you measure angle brachial pressure index?
And systolic blood pressure of the angle, highest systolic blood pressure divided by the highest systolic blood pressure of the brachial artery.
Which brachial artery?
Left.
Always left? Or left leg for left and right leg for right brachial for right leg?
The highest,
Highest.
on both of.
Why? You're right. Why you are comparing both systolic? Any idea? In fact, ABPA means even though you compare the arm systolic pressure, ideally we are comparing the aortic pressure. Okay? So if you take right, sometimes some subclavian lesion is there, this pressure will be less. Or sometimes this lesion will be the left subclavian, this will be less affected. So you take both and take the highest value, which we hope it represents the aortic pressure. Okay, so you're comparing the leg pressure to the aortic pressure, but aortic pressure cannot be measured always, so we take that upper limb pressure. To decrease that error, we take both sides. So you take the highest systolic pressure of both arms, you measure both and take the highest pressure, and again you measure the pressure in the dorsalis pedis and posttibial, take the highest value and divide it. Okay, so it's a ratio of the angle pressure to the highest systolic pressure in the upper arm. Okay, so my patient, your value is 1.4. So you're happy?
No.
Why?
Because
1.4 is good value.
patient is diabetic since it can mask the
How did it mask? Diabetes is a
micro.
mask. COVID പോലെയാണോ? Yes, how did it mask? You're right.
How does the arterial wall, no? How does the arterial wall in diabetes? Yeah,
Calcification.
calcification.
What type of calcification it is? You're right. Yes. What happens to arterial wall? Calcium atherosclerosis. Mongebuck's atherosclerosis will happen. It affects the media. Okay. So it needs, when this calcification means you have to apply more pressure to compress it.
It become non-compressible sometime. So the ABP will be elevated. The BP looks high.
So what will you do? Your
Such
patient does
cases.
1.4.
toe break,
Yeah.
toe brachial.
Toe pressure.
Toe pressure. Okay, fine.
What are the things needed to measure ABPA?
Doppler.
What Doppler?
Dop-
With a routine machine, can you measure ABPA? You can measure, but routinely we will measure ABPA with hand Doppler.
Yes.
Handheld Doppler and a BP apparatus is needed. Okay. Have you seen a hand Doppler?
No.
So,
Where is my laptop? There is a picture for portable Doppler. Irka? Doppler. Doppler illa.
What is significance of ABPA? What significance of ABPA?
So if it is less than 0.9, it is
No, significance. You measure the ABPA. By measuring ABPA, what all idea will get or what all benefits the patient gets?
usually the pressure is more in the ankle. So
Okay, I agree. Normal pressure is 1. If it's more than 1.5 to top pressure, if it's just than 0.4 critical limb ischemia. Why you are doing this? You are telling me that, sir, this patient ABPA is 0.8. So what is it? Why you are measuring?
decreased perfusion of the.
What are the use of ABPA? Yes, planning for a compressed oxygen ABPA, that's good. Okay. Before that, first is diagnose itself. In a doubtful case, you can do a diagnosis of peripheral disease by measuring ABPI. Okay. Second is, you have to decide whether to treat him or not, or conservative or aggressive or not. Okay. If ABPA is less than 0.4, 0.5, that means a critical limb ischemia, he needs early intervention. If it is 0.8 or 1, that means patient is only less symptoms, you can manage with conservative measures. Okay. Third thing is, you are treating the patient, this month you are given some tablets, now it's 0.7, after 1 month patient comes back to you, look at 0.8, that means patient is improving. The same patient come back after 3 months saying that, looking at the APA is 0.6, that means patient is getting worsening. So follow-up of the patient is possible. Fourth thing is, if you do some intervention, you bypass or you do a angioplasty and do follow-up with ABPA, you can see that the bypass is still working or not. Okay. And last thing is, it's a pre-runner of coronary disease or a stroke. If the ABPA is very less, with less symptoms, patient may develop stroke or coronary disease at any time. So that's also a forerunner. These are the 4 or 5 uses of ABPI. So always very easy to do it. You need a hand Doppler and this is a hand Doppler. He will show you how a hand Doppler works. And BPA part, the OPD, surgical OPD, you can do it. Okay. So do it, try to do it, or when you are doing a house science also, you should demonstrate. You should do it. Okay. So we'll show you a hand Doppler how it works and how.
Show the triphasic sound. The normal pulse is triphasic. Strong artery.
No smoking. So it's a strong artery.
Can you appreciate this? Yeah.
Yeah, this is a triphasic sound. See the this is triphasic sound, and even biphasic sound is normal for many people. For athletes, it is normal. When there is high blood flow, even biphasic is normal. If you do running or exercise, and after that, if you measure this phasicity, sometimes biphasic will come. And for normal arteries supplying to heart and brain, where there is high demand, biphasic sound is normal. Okay, and that sound will come as. If I measure this sound for any athlete here, anyone? Sometimes you can get biphasic sound. Or if anyone who uses any kind of substance can get biphasic flow.
Hey, what is the pulse rate for trained athlete? Well-trained athlete. What is the pulse rate?
Any athlete here? Any athlete?
Bradycardia. Yeah, bradycardia. You know Boris Becker. Boris Becker. He is a tennis player. Tennis player. His pulse rate was only 40. There is a.
Have you heard of Carl Lewis?
Carl Lewis.
Yes.
His pulse rate.
36 or 32. That's something like that. PT Usha is only 42. So don't give adrenaline drop if PT Usha is admitted in the hospital. Okay. Please be aware.
They always have bradycardia.
Okay. Yes.
What is normal ABP?
Yeah, mic put mics. Mic is this.
Normal ABPI is more than 1.
Yeah. Always more than 1. Normal ABP is always more than 1 because angle pressure is always more than the brachial pressure. But book says 0.92.
0.91 is enough.
0.9 to 1.3 can be considered as normal according to text.
You can consider 0.9 also normal. Right?
What is TCPO2? Yes, please. Exovirus. What's the important significance? Not only amputation, even the ulcer also you can measure it, and if that's very low, then chance of ulcer healing is very delayed. Okay, it's good centers will measure the TCPO2 of the ulcers also. If it's less than 40 or less than that, then chance of healing is very less. It's more important for amputation terms. Okay. Okay, so no, message is very clear. No, don't do CT angiogram for all the patients. CT angio or MR angio or DSA is required only if you are planning for intervention. Okay? Mild symptoms, somebody who can walk for a kilometer, some mild claudication, then those patients can be treated conservatively. Okay? That doesn't require any intervention, and in those patients don't apply for angiogram because angiogram has its own complications. Okay? What are the common complications of angiogram?
Nephrotoxicity.
Yes. Most of the dyes you give can produce nephrotoxicity. So angiogram is not a simple investigation for all the patients. Once you decide that patient is having a critical limb ischemia. Critical limb ischemia means? What is critical limb ischemia?
Rest pain for more than 2 weeks.
More than 2 weeks in spite of adequate analgesia. Okay, then?
Ankle brachial,
Index?
it is less than 0.5.
0.4 or less or 0.5 authority. Okay.
Then if the toe
Toe
pressure
pressure?
less than 30 millimeters.
Yes, very good.
Then if any ulcers or gangrene is present.
Gangrene, minor or major tissue loss. How do you differentiate minor and major tissue loss?
If only the toes are affected, it is minor tissue loss.
Toes, digits. Okay, fine. So this is a critical limb ischemia, and these patients needs intervention. That is, a patient have a rest pain for 2 weeks in spite of adequate analgesia, or the TCPO, the angle pressure is, ABI is 0.5 or less, or top pressure is less than 30, or the chance of loosening some part of the limb by the limb threatening. These patients needs intervention, and once you decide for intervention, you can go for a angiogram. What test will you do before the angiogram?
RFT.
RFT. Okay, yeah, serum creatinine is 1.7. What will you do?
V.
Eh? Your patient is come for angiogram. You are under sent to do a renal function test. Report comes as 1.7.
Okay. MR.
Eh? Anybody?
MR.
No. The thing is, you want the bomb now or you want the bomb after 6 months? Both are bombs. Okay? If you want the bomb after 6 months, you can do MR angiogram. A reversal bomb also. MR angiogram, what dye you give? Gadolinium. Gadolinium is not a nephro-friendly agent. It can produce nephrotoxicity. It can produce irreversible renal fibrosis. Once it happens, patient will lose both kidneys. So, in a compromised kidney, never try MR angiogram. CT angiogram is a little more safe because it causes acute problem. You can treat it. You can do a dialysis and over to it. But MR angio is not the right answer for having a compromised renal function because it can produce GIN or called gadolinium-induced nephropathy. That's much more dangerous. Only thing is, the patient will not sue you because the patient will go after home or come back after 6 months, not a problem. Okay, but still not the right answer. If 1.7 creatinine is compromised, what will you do? You try to correct it. Okay, what are the options to correct it? One thing is you correct any infection, give any antibiotics and control the infection. Give proper hydration, which will be started at least 48 hours before the procedure and continue even after the CT angiogram, or the patient get adequate urine. Third thing is one drug is there, N-acetylcysteine, you give 600 milligram twice a day for at least 2 weeks, 2 days prior to procedure and continue it after the CT angiogram. Stop metformin because metformin can produce lactic acidosis in a compromised kidney patient. Okay? And last is inform the patient that the patient may get acute renal failure, may need dialysis, but most of them will correct by itself. That should be informed to the patient. After these 5 steps, if again you recheck the creatinine with adequate hydration, all those things, sometimes creatinine may come back to normal, 1.2 or less, you can do a angiogram. If not, the option is, there is angiogram called CO2 angiogram, carbon dioxide angiogram, where carbon dioxide is used as a dye other than these things. Okay, so that is the way it is to be done. Okay, angiogram is done. Your film is with you. The patient is standing with the film. What all things will you look for?
The site of the occlusion.
Yes, good.
The extent of the stenosis.
Yes, excellent.
Then the distal runoff is present or not.
Yes, super.
Then the occlusion of the
Site.
if patient is asked, first pulse is felt and the patient is asked to exercise until claudication sets in, disappears.
Why get disappear?
Because supply and demand is not.
When you do exercise, the muscle will work, no? All the blood will be shunted to the muscles. It will not reach the periphery. It will not come to the dorsalis pedis and posterior. It will be distributed in the calf muscle and they don't have pulse. Then you take rest, it will reappear. This indicates peripheral arterial occlusive disease, but compensated. Such patient you do only exercise therapy.
Okay, you have done a CT angiogram or MR angiogram, and the patient shows in this patient, your patient, 15 centimeter long femoral artery occlusion, symptomatic. Critical limb ischemia, what will you do?
Bypass graft.
Super.
bypass.
Femoro,
Eh?
femoropopliteal.
Very good. Femoral bypass.
Yes.
What material we use?
PTF.
Nature is
below the groin.
Great saphenous.
Yeah, correct.
God given is the best thing.
Great saphenous vein.
You straight away simply put a great saphenous vein or something else will you do?
Reverse, or
Why you are reversing it?
because the valve is present, so
Yes.
it
Okay. Any other option to put the same straight like that without?
valvulotomy is done to destroy the
Yes,
valves.
valvulotome. You can destroy the valve with the valvulotome. Advantage of doing a in situ is called in situ bypass. Other thing is called reversed saphenous vein bypass. Here is called in situ bypass. The same thing is put like that. What are the advantages of doing a in situ bypass? Anybody? Pardon? How? Less chance of graft failure. How? Why there is less chance of? It's in fact graft failure is more, because the valve may not be properly destroyed. Sometimes the valve remnants will be there that causes thrombus and thrombogenic. So if it's not properly done, that carries a higher graft failure. Anything else? See, it's a long vein. If you want to put out the vein, you have to put multiple incisions. Dissection is more. Chance of infection is more. Patient mobility is more. In here, what happens? Only 2 incisions. Take the vein, identify the vein, identify the artery, and just anastomose it. Okay. So less dissection, less chance of infections, less mobility. More than that, if you look at the vein, the upper part is larger, the lower part is smaller. Okay. When you reverse it, the lower artery goes up, lower vein goes up to the artery where artery is bigger. Okay. So size disparity is less with a in situ bypass. But the problem is, if it is not properly done, the valves will affect the outcome, and graft thrombosis more with the in situ bypass rather than a reversible saphenous vein graft. Okay. Then, no vein is available. Patient undergone a CABG earlier, no vein. Then what will you do? You can use a graft.
PT.
Any other vein? Any other vein? Yes. Axillary vein. Arm vein can be used. Okay.
Short saphenous vein can be used.
Can you use any artery? Yes. What are the arterial conduits? One is internal mammary artery. Then, what all arteries can be spared without causing much problem in our body? 2 more. Radial artery. Yes, very good. Internal iliac artery. Okay. Not routinely used for this leg purpose, but these are the other arteries which can be used for limited uses. Okay. So if nothing is available, you go for a graft. Graft causes more thrombus than nothing. Okay. Angioplasty, any idea? We'll wind up because time is. Any idea about angioplasty? It's for very small lesions, very isolated lesions. You put a balloon and apply pressure from inside. You're causing breakage of the thrombus. Okay? That is called angioplasty. We are not going to details of it. Okay. Anything else? Yes? Any questions? The price question? Nobody wants the price? Everyone wants a lunch only, no price. Le.
How much time you walk back? How much time you walk for peripheral arterial occlusive disease? What is the walking advice for the patient? What is the walking advice for a patient with peripheral arterial occlusive disease? What Bailey says? யாரும் Bailey வாசிக்கிறது இல்ல. என்னப்பா? I'll tell the answer. அந்த phone அந்த mic. எல்லாம் கரண்ட் போச்சு. பாப்பா switch off immediately. ஒரு 10 years back the Bailey says 10,000 steps per day. That is advice for all peripheral arterial occlusive disease. Those who are on graft, those who are on stent. Everyone should walk 10,000 steps. Then when 5 years later, when Bailey says 45 minutes per day, 5 days a week. 45 minutes per day, 5 days. That latest Bailey says at least 2 hours of brisk walking per week. At least 2 hours of brisk walking per week is the advice for a patient who's on graft, who's having peripheral arterial occlusive disease, who's a claudicant or post bypass. This fem bypass, fem popliteal bypass. Okay. And you have to give atorvastatin, ecosprin, platelets, antiplatelet, atorvastatin also you should give for these patients. When you put the patient on stent, clopidogrel also along with the dual antiplatelet you should give, right? Then diabetes should be controlled, HbA1c should be less than 7, fasting should be less than 120, postprandial should be less than 160, and cholesterol, dyslipidemia to be controlled. Then only your graft will survive.
Smoking should be stopped.
Yeah, smoking should be stopped. Stop smoking, start walking. That is the previous advice. And when we study MBBS, what is the treatment for claudication? Stop smoking, start walking. That's all. Everything will reversible. So
What is
please,
it? What is elastosol? How it? What's the mechanism? What class of drug it is? Phosphodiesterase 5 inhibitor. Okay. Yes. What is the common problem with silososol? Adverse effect? It's a short note, silososol. Yes? It can produce head. It can produce peripheral vasodilatation, head vasodilatation also. It can produce severe headache. Vascular headache.
nitroglyceric ointment what you are applying for fish and that also produces intense headache.
What's the contraindication for silososol? Absolute, no. Absolute contraindication. You are almost on the. Where should not use silososol in a patient? Cardiac failure. If the patient is in failure, never use silosol because further vasodilatation can damage the patient. That's a doubt. When the food comes, that's a doubt. Okay. So, very good. Excellent presentation. Very good answering. Keep up. Okay.
I think all the students, they prepared very well. It seems to be. They studied the subject also. Yeah, because I stood as a chairperson for 2-3 sessions. I think all the students, they prepared well and they studied the subject also. That is very important. Especially the last girl, she did extremely well. So every day before you sleep, you play. Every day 45 minutes, you study, then sleep. And do one good thing to the society. That's all. Every day. Right? These 3 should happen. Play, enjoy, and you should help we should help someone. Then study and then sleep.
Big hands to you and the department. Department is preparing you very well. Congratulations to all the department.
Hey, Noble, Dr. Noble, I think I went as a MS examiner for him. I didn't know that. He recognized me that I have gone as a MS examiner when he studied in Tirunelveli. I congratulate him. He is the youngest vascular surgeon now in our district. In India, yeah. Very intelligent boy. But boy. For me, he's a boy. I give a memento to him.